Can I have the next speaker introduction, please? Our next speaker is Dr. Arti Behl. I think rightly positioned, we have now a psychiatrist when we are talking about how the mind can control. She's an MD psychiatry from KMC Manipal, plus an additional PGDMLE from Bangalore again. She has been working as a psychiatrist from KMC Manipal. She's authored 2 books, and her special interest has been on mental disorder in women, OCD, medico-legal aspects of psychiatry. Ma'am, over to you. May I kindly request you to keep your presentation to 20 minutes?
I'll definitely try.
Thank you, ma'am.
Thank you. Am I audible and visible?
Ma'am, you're audible. Can you make your slides on a slideshow mode? Slide is also visible on a slideshow mode, please.
Yeah.
Yeah, perfect.
Fine now? Yeah.
Yes, perfect, ma'am. Thank you.
At the outset, I would like to thank the organizers of Synapse for having me here. A big thanks to Vaishali for being so perseverant in her mind-body medicine endeavors. A big applause to you, Vaishali. And I would also like to thank Dr. Hemant for his talk on neuroendocrinology, because he's done half of my work and I will do the rest of it, whatever is possible in my hand. Now, we all know that, he spoke about the satiety center, how your energy drives you to eat, etc. But do all of us eat that way? I'm sure we'll get an answer, none of us do. So otherwise, we wouldn't be gaining so much of weight. So the how and what of eating is very, very important, and that is what is controlled by our brain. We all know that, he spoke about the satiety signals, the signals going up by the circulating hormones, the nutrients that make us feel that we've had enough and, this is where we need to stop. But there's a devilish side of our brain. And the good side was what Dr. Hemant spoke about. I will be speaking about the devil in our brain. That is known as the hedonic system or the pleasure-seeking system. The hedonic control, it depends on the rewarding features of food, the time of food. So even if you've had your food at, say, some snack at 1 p.m., 2 p.m. is your lunchtime, I have to have food. The season, winter time, I have to have my pakoras with chai. Your emotion, I'm feeling frustrated, I go open the fridge door, I see a big, huge piece of cake lying in front of me, I need to eat it. The cognition, learning, memory, and social cues. I've had a good time with my friends sometime. I had an apple pie that time. I associate that memory with a comforting food, and I want to have an apple pie the next time I see it. So these are the things which drive a person to eat more or eat when they don't even feel hungry. Both the systems are interlinked, and we just want to say that the hedonic control centers lie in the hippocampus, the amygdala, the VTA, nucleus accumbens, and the prefrontal cortex. Just a minute. So this is your devil that's talking to you, making you pick up the chocolate chip cookies and not making you pick up the fruits and the veggies. These circuits are also mediate the reward response to drugs of abuse. So when we talk about food as an addiction agent, yes, it could be possible. They make palatable foods attractive, even in the absence of energy deficiency. So even when you're not hungry, you feel like eating food. Hedonically pleasing substances like food, sex, drugs of abuse stimulate dopamine release in the ventral tegmental area that project to the nucleus accumbens. So here is where we talk about the dopamine reward system and then wanting to do that thing again and again. The hedonic circuit may override the homeostatic circuit in fed state by increasing the desire to ingest tasty food. Now, how do we know it? There are a lot of PET and the fMRI studies which have shown that in obese persons, we see a greater response in food cues when in the hedonic pathways. So that is how, you start eating. Now, after eating, when you don't listen to the good side of your brain and the devil takes over, you obviously, all of us tend to gain weight and many of us become obese. How does obesity cause behavioral changes then? How does it affect your brain and then lead on to behavioral changes? So Dr. Hemant was alluding to neuroinflammation and the obesity link. Obesity is characterized by a low-grade inflammatory state. This is likely to influence the neuropsychiatric status due to the effects of inflammation on brain activity and behaviors. The concentration of inflammatory markers like CRP and interleukin-6 have been associated with depressive symptoms in obese subjects versus depressive symptoms in non-obese subjects. Reductions in inflammatory markers also follow weight loss induced by bariatric surgery. So along with the reduction in inflammatory markers, there's significant improvement in depressive symptoms and the psychological status. So what all do we see in inflammation and obesity? We see an increased levels of pro-inflammatory cytokines like interleukin-1 beta, interleukin-6, tumor necrosis factor. There's accumulation of leukocytes, mainly macrophages within the adipose tissue and other organs, activation of macrophages in the liver and fat, and there's activation of pro-inflammatory signaling pathways in multiple organs that leads on to this inflammation because of obesity. So how does it affect the central nervous system then? And we all know that, microglia, if it is activated to an extent, it is actually protective in nature for our brain. But this unregulated and chronic activation in case of obesity leads on to a deregulation of the microglia, which then increases the cytokines. What do these cytokines then do to our central nervous system? These pro-inflammatory cytokines, one, they activate the neuroendocrine system, which the previous speaker has been referring to. They impair the neurotransmitter metabolism. Now, neurotransmitters, we know, are very important in functioning of the brain, in presentation of psychiatric symptoms, in the behavioral symptoms. We all talk about only neurotransmitters and neurocircuits. So when these neurotransmitters get affected, either by upregulation or downregulation of the receptors or metabolism of the monoamines like serotonin and dopamine, that itself will produce psychiatric symptoms or behavioral symptoms in a person. Also, the inflammation can alter neural plasticity and brain circuitry, which is very prominently seen in hippocampus and hypothalamus. Interferon alpha also induces major depression by causing inflammation in the hypothalamic pituitary adrenal axis, neurotransmitter function, and the enzymatic pathways involved in monoamines. The enzymes which are involved in these amines, monoamines, which are either, which they get deregulated because of the inflammation, are these indolamine 2,3-dioxygenase and GTP-CH1. These changes are more characteristically, like I said, seen in hippocampus. So this is what we see in chronic inflammation of obesity. A lot of macrophages get accumulated within the fat cells or the adipose tissue, which secrete inflammatory factors like interleukin-6, tumor necrosis factor, etc. Same thing happens with the gut. Due to the change in the gut microbiota, the gut permeability increases, which leads to low-grade endotoxemia, which also generates a lot of inflammatory markers like LPS, which in turn will reach the brain and cause these problems associated with inflammation. Now, inflammation is not the only process that takes place when obesity is present. This endocrinism causing insulin resistance, leptin resistance, and hypothalamic pituitary adrenal axis dysregulation itself causes a lot of changes in your behavior and neuropsychiatric symptoms. Then there is also dysmetabolism due to obesity, dyslipidemia, hyperglycemia, and hypertension. That itself lead on to a lot of problems like small thrombotic episodes that take place in the brain, which cause a lot of changes in the brain. So the unhealthy brain because of this actually is a result of the neuroinflammation, like I talked to you about the microgliosis, the changes in the monoamine metabolism, the hypothalamic and the hippocampal inflammation, which leads on to neuroprogression, that is reduction in the neuroplasticity. So, the changes and the pruning of the neurons in the brain are affected. The prefrontal cortices anomalies take place. I'll be talking about this in a few minutes. And neurodegeneration like the hypothalamic gliotic scars, hippocampal atrophy causing memory deficits, cortical degeneration, and neurocognitive decline, and sometimes which leads on to dementia as well, is seen because of obesity. So the adipose tissue, the gut, releasing cytokines, this inflammatory markers reach your brain, causing a lot of problems in specific areas like the prefrontal cortex, the hippocampus, hypothalamus, basal ganglia, leading on to problems in the monoamines like serotonin and dopamine, in the neuroendocrine system like the hypothalamic pituitary axis, causing problems in neurogeneration, neurotoxicity, which in turn leads on to behavioral alterations and neuropsychiatric symptoms, which in turn, again, makes a person more prone to an obese state. So this is what we discussed about how obesity affects your CNS. How are obesity and psychiatric disorders then related to each other? It obviously has a bidirectional relationship. I'm sure many of you who are seeing obese clients in your clinic know how their mind affects their body. Hyperphagia and limited physical activity are the most direct behavioral determinants of obesity. Many of the psychiatric symptoms or psychological disorders also manifest with hyperphagia and limited physical activities. To name depression, schizophrenia, even bipolar depression, all these things lead on to hyperphagia and limited physical activity because the patient doesn't have motivation to do anything. And then, here is where I want to point out to clinicians who practice treatment for obesity is that the time management of when you actually intervene for obesity in patients who are showing psychological symptoms is very important. If you don't intervene at the right time, whatever you tell them to follow is obviously not going to hit them inside their brain. Hence, let their psychological problems be taken care of and then start the intervention for obesity as well. These kind of hyperphagia and limited physical activity is also used as means of coping during distress. Chronic stress can also be associated with obesity. The next talk is about psychosocial issues, so I won't delve too much into it, but the main causes of stress and obesity are stigma, medical comorbidities, and the impairment in quality of life. Majority of the studies have focused on depression, and we see a higher rate of depression in obese women and in patients who have more severe obesity, which is usually, accepted. And patients with obesity have a 55% increased risk of developing major depressive disorder in their lifetime. Vice versa, patients suffering from major depressive disorder have a 58% risk of developing obesity. Atypical depression is a component of depression in which, usually seen in bipolar depression, in which patient has hyperphagia and hypersomnia. They tend to gain a lot of weight during this time. Also, I came across this concept of metabolic mood syndrome when I was reading about obesity and depression. Obese persons also are likely to have anxiety and bipolar affective disorder, and this relationship is stronger in women. And patients who are obese with bipolarity are likely to have more frequent manic and depressive episodes and more frequent suicidal attempts, which we have to be careful about. Another disorder which most of the obesity physicians are not aware of is eating. I mean, they may be aware of, I beg your pardon, but what they don't deal with is eating disorders. It's generally neglected in that sphere. Binge eating disorder, bulimia nervosa, and night eating syndrome are commonly associated with obesity. Now, binge eating disorder occurs with other psychiatric problems also, like depression, anxiety, substance use, and personality disorder. And many a times, even in a psychiatric clinic, it usually goes unnoticed because, we see the bigger things like depression, anxiety, and substance abuse, and we tend to neglect the binge eating disorder. In this, the patient consumes excessive food, there's loss of control over their eating, and there's subsequent distress associated with eating. So they feel very guilty after it. But how we differentiate it from bulimia nervosa is that in bulimia nervosa, usually they get into a compensatory behavior of either vomiting it out or exercising excessively or using some kind of laxatives, just to get rid of the guilt associated with overeating. Night eating syndrome is another disorder in which more than 25% of calorie consumption in a daytime, in the entire day, 24 hours, is done beyond 7 p.m. These people also get up in the middle of the night and eat high calorigenic food and sleep off. So these are things which are associated with eating disorders. And binge eating disorder also has a worse off metabolic profile. The main element of binge eating disorder and obesity is emotional dysregulation. Now, emotional dysregulation is a concept this is a symptom which we see in many psychiatric disorders. We see it in depression, we can see it in substance use, we see it in schizophrenia, in mania, in which the patient doesn't know how to deal with their stress. And binge eating disorder is also associated with it. There's a poor understanding of even these reactions. So they react in a wrong manner and they don't learn from their reactions. So they don't learn from a previous mistake made. There's maladaptive strategies of coping like uncontrolled eating. And this is what makes binge eating disorder so difficult to deal with. Binge eating disorder, comorbid with obesity, is more challenging to manage because it has poorer outcomes due to both psychological and medical complications that are associated with it. Another disorder, that is attention deficit hyperactivity disorder or hyperactive disorder, ADHD, is very commonly associated with obesity. Again, gets missed even by psychiatrists, which I want obesity physicians to be aware of. ADHD is characterized by inattention, hyperactivity, and impulsivity. The prevalence of ADHD in populations with BMI more than 30 may be as high as 27.4, and the general population, the prevalence is only 3 to 4. Association is stronger in adolescents and adults because as children, they're not obese, but over time, because of that lack of control over eating, they tend to gain weight as adults. Dysfunction in brain reward pathways, emotional dysregulation, again, this concept is coming here, and executive functioning being impaired. I'll just be talking about the executive functions. All this causes the person to go on eating without having any sense or control over it and making them put on weight. Inattentiveness would lead on to skipping meals. That would in further, lead on to odd time snacking and binging and, making them consume more of calorigenic food and thereby gaining weight. Also, short sleep duration is associated with ADHD, and that we know is one of the risk factors for obesity. So we see in the neurodevelopment features a cyclothymic temperament in which the patient suddenly reacts, goes up and down in the temperament, in the mood. There's emotional dysregulation, executive dysfunction, impulsive and addictive behaviors. All together make a person more prone to have mood disorders and ADHD, which make the person more prone to have eating disorders, which in turn make the person more prone to have obesity. Executive function is something which is controlled by the prefrontal cortex. So in this, whenever we have to do a task, we need to plan, we need to have some kind of a control over it, we need to execute it and then, manage it accordingly. But the prefrontal cortex, because I said it is affected by obesity-related inflammation, there may be executive dysfunction in obese patients. That leads on to poor inhibitory control. So the prefrontal cortex tells us not to do, what not to do. It's like a brake for our brain. So it has poor inhibitory control, which leads on to detrimental eating patterns, either in terms of overeating or eating, calorigenic food. There's also impulsivity in executive dysfunction, which was also a feature, like I mentioned, in ADHD. This makes the person have a tendency to react abruptly to a stimulus and have immediate gratification. So people who cannot wait for a long time to get results, that is known as immediate gratification. These people who have executive dysfunction don't have that control over them, which makes them have more of emotional eating and go in more for high calorigenic food. The reward hypersensitivity and intolerance for deferred gratification, again, they don't have tolerance for delayed gratification at all, makes their dietary choices towards high caloric foodstuff. Now, coming to obesity and cognitive effects, we all know that, obesity is more closely related to some kind of deficits in your memory and other cognitive spheres. Planning, problem solving, mental flexibility, and inhibitory processes are affected. Like I said, they're all controlled by the frontal lobe, especially the orbitofrontal cortex. Significant decreases in the hippocampal dependent learning. Like I'll just remind you that, hippocampus is one of the areas which is getting affected by the inflammation related to obesity. And there's relationship between the CRP levels and decreased performance on frontal lobe cognitive functions in obese women reported by a study. In patients with metabolic syndrome, high levels of CRP and interleukin-6 were found to increase the risk of age-related cognitive decline and sometimes even dementia later on. So here we have these behavioral dysfunctions like poor self-control, not having enough of self-regulation, which makes the person gain weight, which leads on to dysendocrinism and dysmetabolism, which then causes inflammation and other changes in the in the central nervous system, causing prefrontal cortical disturbances, hippocampal and hypothalamic disturbances, which in turn, again, cause a lot of other neuropsychiatric dysfunctions like reduced cognitive or executive functions, reduction in emotional regulation, and other interoceptive awareness. And because a person suffering from neuropsychiatric dysfunction will obviously exhibit behavioral dysfunction, and hence this vicious cycle just goes on and on. My last two slides, it'll be on the psychiatric medications which are commonly associated with obesity. Atypical antipsychotics, among them clozapine, olanzapine, and risperidone, are known to induce a weight gain. Mood stabilizers like lithium and sodium valproate, the latter also causes PCOS. Antidepressants, the tricyclic ones like amitriptyline, imipramine, clomipramine, they all cause weight gain. A few SSRIs given long-term like sertraline and escitalopram as well may cause weight gain. So before starting the medicines, check the patient's BMI, check for a family history of obesity, even diabetes mellitus, dyslipidemia, etc., and then decide on medicines, because most of our medicines are long-term medicines. We can't be affording to make the patient go through so many other metabolic disturbances. Check weight at 4, 6, and 12 weeks. Consider changing in case of weight gain, but please keep in mind the risk versus benefit of changing. If it's going to affect the psychiatric status to an extent that the patient becomes suicidal, let him gain weight and we can wait and watch. Weight-friendly medications are the antipsychotics are aripiprazole, ziprasidone, amisulpiride, lurasidone, and cariprazine. The antidepressants which are weight-friendly are fluoxetine, vortioxetine, and mood stabilizers like lamotrigine and topiramate. I would like to end my talk with a sentence which two wise men have said: obesity is a normal response to an abnormal environment. I think we are born with some kind of genetic predisposition. It's like a loaded gun, but all we have in our hand is changing of environment. So I think we all should stress on that. Thank you so much.
Thank you very much, ma'am. I think you really brought it beautifully. Like, I think obesity is something that has to be addressed in the childhood itself, because looks like if I'm not going to address it in childhood, that neuronal problems that are going to happen goes on like a vicious cycle in itself, right, from obesity to unhealthy brain to inflammation, and again going on into the loop and making it worse before it becomes worse. Address it at childhood. So I hope you're there with us till the end so that we can take the questions at the end.
Yes, I'm there. I'll be there.
Thank you. Thank you very much for that, ma'am.
Thank you.
I really appreciate you could keep up with the 20 minutes so that we have the other speakers also to go on. To the organizers,